So we're going to move right ahead. Les Robison, come on.
Thank you. I welcome the opportunity to be able to speak today about some of the experience that we have had in a different population of patients, that is, long-term survivors of pediatric cancer. And what I really have been asked to do is to demonstrate, how we've approached long-term surveillance, long-term outcome assessment of a population of pediatric patients that have been exposed to a variety of treatments following cancer as a potential paradigm for how long-term follow-up can be carried out within the context of not only clinical trials, but also within the context of just long-term research protocols. So what I'll do first of all is talk a little bit about the childhood cancer survivor cohorts that currently exist in the United States and have been in existence for some time. I want to talk a little bit about, from these cohorts, what we've learned, just some selected points that have demonstrated, I think, very important aspects of long-term follow-up. The first we'll talk about retrospective versus prospective ascertainment of populations and outcomes, but also in terms of ascertaining the long-term outcomes. Patient-reported versus actual clinical assessments, what we've been able to learn. Issues about the cumulative burden, and that is the idea of not just looking at one or two endpoints, but multiple endpoints that might be experienced from these populations. Issues relating to record linkage and our ability to monitor long-term, and then also I'll touch upon a little bit about mobile health or mHealth approaches to be able to monitor patients remotely. So first of all, in terms of childhood cancer survivors, just to give you a context, the survival rates for childhood cancer in the United States and in most developed countries are exceptional now, with 5-year survival rates now exceeding really about 85%. It's a rare cancer, though. It's a rare population, I should say. There's only about 13,000 children under the age of 15 diagnosed in the United States each year with cancer. That's less than 1% of the cancer burden in the United States. So it's a very small population, a very heterogeneous population relative to diagnoses and treatment approaches. But with these increasing survival rates, which you can see from the survival curves generated from the Surveillance, Epidemiology, and End Results program of the NCI, survival rates have increased substantially. What isn't shown here is survival rates for back in the 1960s, where the long-term survival rate was about 25%. So basically from the 1960s to the 1970s, there was a dramatic increase in terms of survival rates that really created a large population of survivors, which at the end of 2013, again based on population-based statistics in the U.S., we estimated that over 420,000 individuals had been diagnosed with cancer during childhood that were living in the United States. That turns out to be a prevalence of about 1 in every 750 individuals in the U.S. is a survivor of childhood cancer. Our projections are that by the end of next year, there will be over 500,000 individuals in the population who have been diagnosed and treated for cancer during childhood. Now, we started to recognize quite some time ago that there's long-term consequences to the treatment that children with cancer receive. Because of that, the National Cancer Institute has actually funded 2 large childhood cancer cohorts that I'll describe to you in a little bit in detail. The first one is the Childhood Cancer Survivor Study, which has now been funded. We're now in our 24th year of funding from the National Cancer Institute. This is a cohort that is a little over 35,000 individuals from multiple centers, 31 centers across the United States. We currently are actively following a little over 24,000 of these individuals. And you can see geographically, they're very distributed across the U.S. So that in and of itself creates some very significant issues in terms of monitoring, contact, and overall follow-up. Now, the Childhood Cancer Survivor Study does background. We initiated it primarily because the majority of these patients were treated on clinical trials through the National Cancer Institute's cooperative clinical trials groups. The Childhood Cancer Children's Oncology Group now, which is the combined Children's Cancer Group and Pediatric Oncology Group. So the majority of these patients were actually treated on clinical trials, either those or some institutional trials. But what we realized back in the mid-1980s, these patients weren't under active follow-up anymore. And in fact, we went back and actually looked, and 2/3 of the patients diagnosed from 1970 through 1985 had not been seen for over 10 years by their pediatric oncologists. So they were basically not under active surveillance within that group. So that was the rationale for starting the CCSS. The St. Jude Lifetime cohort is a more recent cohort. This is institutionally based. It's only patients who were diagnosed and treated at St. Jude Children's Research Hospital in Memphis since the time the institution was opened in 1962. This is a cohort that was initiated through research at the institution, but is now subsequently funded by the National Cancer Institute. And to give you a sense of how these two differ in terms of their own characteristics, all of them are 5-year survivors. So we only use 5-year survivors because of the issues of cost and so forth to collect information during the acute phase. And most of them are under active surveillance during the acute phase. The diagnoses, the CCSS, we had to limit to the most common pediatric cancers because of the funding restrictions from the NCI. Both are retrospective cohorts with prospective follow-up. So we basically went back in time, identified everybody that met the criteria, the eligibility criteria, recruited them, and now we are longitudinally, prospectively following them. But we do it in two different ways. The Childhood Cancer Survivor Study is all survey-based. So we contact direct with the participant and collect health status on a periodic basis. Most of those data are all, again, self-reported. We do validate some of the outcomes, such as second malignancies and so forth, but we're relying on self-reported quality of life, but also diagnosed and treated health conditions. For the St. Jude Lifetime cohort, this is a clinically based cohort. So these are individuals that we bring back to Memphis, and we actually clinically evaluate them over a 3 to 4 day period of visit. Very extensive clinical assessments, and that's important when I show you a little bit of data in terms of the difference you get when you do self-reported, clinically diagnosed outcomes versus direct clinical testing and assessment. Both of them have comparison populations, and that's something that is extremely important, and it was nicely touched upon in the previous talk. We need to know for long term, we have to have a reference population in terms of what events might be expected to just normally occur and at what rate in an appropriate age, sex, race population. So both of these have controls. The Childhood Cancer Survivor Study, we rely on siblings. So we have a sibling control group, which is very good for some things, not so good for other things in terms of some of the psychosocial, socio-demographic outcomes. Obviously, they're not ideal or genetic outcomes. For the St. Jude Lifetime cohort, we use a community control. So these are not related in any way to pediatric cancer survivors. Therapeutic exposures, very critical in both of these. Very detailed information, cumulative doses of all chemotherapy. Radiation therapy is performed in terms of dosimetry to organ-specific doses so that we know exactly the exposures. Surgical reports are available. We also have other treatments such as aminoglycoside exposures and so forth within these populations. And then lastly, banking of samples, which was just mentioned. This has been a very key and important part of the research that we do. So we basically bank peripheral blood on all these individuals. In St. Jude Life, we also bank urine as we go forward. So with that as background, let me talk a little bit about retrospective versus prospective. We got behind the ball in the pediatric cancer survivor population. We didn't realize they weren't really being followed well until they were really quite a ways out. So let me just walk through the initial recruitment. We identified 20,270 eligible individuals. Of those individuals, over 8,000 of them required tracing. So otherwise, we couldn't locate them based on the information that their treating institution had for them at the last contact. But what really hits is that of those almost 8,000, almost 3,000, we couldn't find them. These are pediatric patients. You don't have necessarily Social Security numbers on everybody. You don't always have it on patients. People are very mobile. But basically, we ended up with an extensive amount of effort and cost, still couldn't locate 3,000 of these individuals. Of those that we did locate, we were able to successfully contact a little over 17,000 of that initial recruitment cohort. But here's some other things you start to learn if you do this in a retrospective approach. So of those 14,000 or 17,000 that we initially contacted, 14,000 agreed to participate in the study. So we had 82, had 18% that basically are non-participants, and much of this was basically non-response. They just didn't respond to us. Some actively refused. But here's another thing, to sign a medical release so that we can have access to their medical records. We had essentially 1,300 individuals who provided all their extensive self-reported health status, all the information to us, but they refused or declined to sign a medical release so that we could actually get access to medical records, even for the release of their cancer treatment. So if you wait, for whatever reason, individuals were very concerned about giving us carte blanche access to their medical records. But basically, if you look through this, the numbers start to diminish pretty rapidly. So at the end of the day, 72% of the eligible population were successfully recruited into the study. That's because we lost them. We shouldn't have lost them in the first place. That probably would have increased. As well as if we'd started the collection of information, the education of the population at an earlier time period. So retrospectively doing this, there's some downside to it, very clear downside. We are advocating very strongly that going forward, this should be done on a prospective basis. Consenting at the end completion of therapy, starting to collect information on a periodic basis going forward. So in the time remaining, I want to talk to you a little bit about ascertaining outcomes. And we know for a cohort study, one of the real strengths of a cohort is you can look at multiple outcomes. You're not restricted to just one. You can actually look at a variety. And we know that pediatric cancer survivors are at risk for a lot of different types of adverse outcomes, as shown on this slide, from growth and development, organ function, fertility, carcinogenesis, psychosocial outcomes. But also what we found is that while these individuals are being seen in the medical community, you can see that relatively high by 25 years of age in these survivors, that roughly between 80 and 90% of them had had been in contact with the medical care system within the last 2 years. But more importantly, if you look down at the green and the black lines, those are populations or medical areas that are actually designed specifically to follow up on pediatric cancer survivors or survivor populations that basically know the risks, what to look at, how to be assessed. So and it declines obviously with time. But here's what we've found through this is in the St. Jude lifetime cohort. So the blue lines on these next two slides, this demonstrates the self-reported health status of the patients for the various outcomes that are listed. So basically before we brought them back, they filled out questionnaires and told us what they'd been diagnosed with by their healthcare providers going forward. These are within groups that are known to be at high risk. So the first one, in terms of abnormal pulmonary function, they received pulmonary toxic therapy, either chemotherapy, chest radiation, or thoracotomy. And the blue line shows what the cumulative prevalence of abnormal pulmonary function is in that population. Well, the red line is what the actual pulmonary function dysfunction is within this population when you carry out pulmonary function studies and bring them back in. The same thing for hearing loss in individuals who had actually received platinum agents. And the other one on the far right is breast cancer. Female survivors are at high risk for breast cancer following chest radiation. This is how much from one mammogram we were able to ascertain by bringing individuals back. You can see similar patterns in others. Pituitary dysfunction, not so much because it comes immediately to clinical detection. But when we start to look at the age and the duration, these occur over time, over long, extended periods of time, so not just in a short interval. You can see, and we grade according to the common terminology criteria, CTCAE criteria from NIH, of chronic health conditions, with grade 3 and 4 being severe, disabling, or life-threatening conditions. And you can look at it according to age of the individual versus the time from diagnosis and treatment of their cancer. But it's really an issue of cumulative burden, too, that we wanted to emphasize. It's not that it's just the time to the first occurrence of a chronic health condition. They're experiencing multiple. And so we've looked at this entity referred to as cumulative burden, where you can look at on average. So basically, these curves show that by 45 years of age, on average, a survivor will experience approximately 4 severe, disabling, or life-threatening conditions. That's 4 on average. That's a very young age. But the other thing to emphasize is as we follow long-term, here's the control population. There's morbidity occurring in just the general population as the individual's age. We need to know how much of an increased risk there might be. The other outcome of this is you can actually look at these according to organ function. And this is a population that has really severe multiple morbidity. As you can see, some of it increases substantially with increasing age. Now, how can we follow up? We did this according to bringing patients back. That's probably not realistic on a large scale. We do it because of very large philanthropic support to actually pay for the testing that we bring patients back. But we can also do some other things in terms of record linkage. In the U.S., we're limited compared to many of the Scandinavian countries and so forth in our ability to really do high-quality linkage. We can link to the National Death Index to identify individuals who may be lost to follow-up, whether or not they have higher mortality and what the cause of mortality is. The NCI is in the process now of creating a virtual national cancer registry that can be used for linkage. So we can now, in the future, we'll be able to link populations to identify whether they've been diagnosed with cancer in any of the 50 states in the U.S. There's administrative databases that can sometimes be used with varying levels of degree and some very specialized ones. We've linked with the National Organ Transplant Registry, with the Assisted Reproduction Registries. So there are some abilities in long-term follow-up that don't necessarily require direct contact either through self-report or other approaches. So lastly, though, earlier this morning it was mentioned about mobile health and using monitors and so forth, and we do that. We use accelerometers on our patients and so forth. And yes, you do generate a large volume of data, very useful data potentially, though, if you apply the right kind of approaches in terms of machine learning. Artificial intelligence can help to actually decipher some of those patterns. But here's an approach that we're going to start to rely on more, and that is mobile health for self-reporting of symptoms. Because we know that if we see individuals once every 2 years, we're potentially going to miss a lot of early onset. We've been able to actually show that using handheld apps, mobile devices on apps, that you can actually have individuals self-report their symptom profiles on a regular basis. And with this approach, we've actually now been able to show that we actually can get high participation rates where individuals for up to 3 months are still reporting at 83% in terms of providing us with at least 5 days of symptom reporting so that we can start to learn who's getting into trouble, what types of symptoms are actually occurring as they go forward. So I'll end with this. This is a slide we use in our pediatric cancer survivors. We're interested in looking at long-term outcomes, very long-term, lifetime outcomes, because 2 things that we're interested in. One, which is, are we potentially seeing earlier onset of disease, of morbidity within this population? Which is, we are seeing a lot of evidence towards that. But ultimately, you have to follow lifetime to really understand whether or not how much of an excess in morbidity might actually have been created because of the treatment exposures that these patients may have received. So in essence, for gene therapy, for some of these novel approaches, one can change this in terms of not necessarily age, but you could look at any time interval from the time of treatment, monitor as you go forward, but basically we need to have long-term constant surveillance because you do have emergence of late occurring events within populations. We know that it does in our pediatric populations. One can anticipate that it's potential within other treated groups. Thank you very much.